Mesdames et messieurs les ministres, chers collègues, mesdames et messieurs les représentants et représentantes des organisations internationales et de la société civile, mesdames et messieurs les professionnels de santé et des soins, mesdames et messieurs. Je suis très heureux de participer à ce nouvel événement de l'initiative sur la place des femmes dans le secteur de la santé et des soins. Alors que l'année internationale des personnels de santé et de soins touche à sa fin, il était fondamental de nous réunir à nouveau pour rendre hommage à celles qui soignent. Il est également essentiel de continuer à promouvoir notre initiative qui a créé une réelle mobilisation internationale et ce, en quelques mois seulement. La France est particulièrement reconnaissante envers ses partenaires, l'OMS, Women in Global Health, qui ont porté avec nous ce beau projet pour promouvoir la mise en place de politiques d'égalité entre les femmes et les hommes dans les secteurs de la santé et des soins. Nous l'avons déjà dit à de nombreuses reprises, la crise du Covid-19, en touchant de manière disproportionnée les femmes, qui ont été en première ligne face à la pandémie, a exacerbé les inégalités préexistantes. Elle a aussi, heureusement, permis une prise de conscience. Des agents de santé qualifiés, ayant accès à la formation tout au long de la vie, équipés, protégés, sont le fondement de systèmes de santé efficaces, résilients, équitables. Elles, et ils, mais majoritairement elles, sont aussi la meilleure barrière contre les pandémies. Pour la France, il s'agit d'une priorité nationale, qui s'est traduite dès juillet 2020 au travers des assises appelées Ségur de la santé. Nous avons pris des engagements ambitieux pour améliorer notre système de santé au bénéfice des Français, en donnant des moyens et des perspectives nouvelles à l'hôpital et aux professionnels de santé de ville et du secteur médico-social, parmi lesquels une majorité de femmes. La France a investi plus de 9 milliards d'euros pour reconnaître et revaloriser les métiers du soin, 9 milliards d'euros par an de hausse de salaire, auxquels on ajoute cette fois-ci 19 milliards d'euros d'investissement pour nos hôpitaux et nos EHPAD. J'ai voulu que ces accords se traduisent très vite sur la feuille de paye des soignants. Aujourd'hui, plus de 1,5 million de personnels des hôpitaux et des établissements pour personnes âgées perçoivent au moins 183 € net de plus par mois et un vaste chantier de revalorisation des salaires des agents du secteur public est engagé avec des mesures qui bénéficient également aux personnels concernés du secteur privé. Comme je le disais, 19 milliards d'euros ont aussi été engagés pour moderniser rapidement les hôpitaux, ainsi que l'ensemble de nos établissements médico-sociaux, dans le but d'améliorer les conditions de travail et de sécurité des professionnels, mais aussi évidemment l'accueil du public. Le Ségur de la santé transforme désormais la vie à l'hôpital et ouvre la voie à une nouvelle gouvernance plus participative qui donne davantage de place aux femmes d'ailleurs, grâce à la mise en place de référents égalité professionnelle dans les établissements de santé, animés en réseau par nos agences régionales de la santé, mais aussi la création du Fonds pour l'égalité professionnelle dans la fonction publique hospitalière, pour des projets qui permettent l'égal accès aux responsabilités professionnelles et la prévention des violences sexuelles et sexistes. J'ajoute que le Parlement français a voté le 8 novembre dernier la loi permettant la ratification de la Convention 190 de l'Organisation internationale du travail sur la violence et le harcèlement au travail. La ratification officielle arrivera d'ailleurs sous peu. J'encourage tous les pays qui ont rejoint notre initiative à ratifier cette Convention 190. C'est un pas indispensable pour garantir la protection contre les violences et le bien-être au travail. À ce jour, une quinzaine de pays ainsi qu'une trentaine d'ONG ont déjà marqué un intérêt ou pris des engagements dans le cadre de l'initiative sur la place des femmes dans le secteur de la santé et des soins. Cette première année a été celle de la mobilisation. 2022 sera celle de l'action concrète pour améliorer les conditions de travail des personnels de santé sur le terrain. Nous sommes convaincus que ces actions en faveur de davantage d'égalité entre les femmes et les hommes dans la santé auront des effets multiplicateurs, accélérateurs de renforcement de nos systèmes de santé et d'extension de la couverture sanitaire universelle, visant à permettre à toutes et à tous un égal accès à des soins de qualité partout dans le monde. Merci à toutes et tous, je vous souhaite un excellent événement.
Minister Varane, Health Minister from France, Ambassador Seydoux, distinguished panelists, ladies and gentlemen. It's a pleasure to join today's celebration of UHC Day, the International Year of Health and Care Workers, and the Gender Equal Health and Care Workforce Initiative. It's a year ago, almost, that the initiative was announced by the government of France on UHC Day 2020, aligned with their work on the Generation Equality Forum and the partnership with UN Women as co-hosted by the governments of France and Mexico in preparation for the Paris meetings that were happening earlier this year. The initiative aimed to increase the advocacy, the visibility and the actions on the agenda of women in the health and care workforce, which is so notable this last 2 years with the COVID-19 pandemic, in addition to what we knew before. And it was through a partnership of a government, France, a non-governmental organization, Women in Global Health, and a UN agency, WHO. So a slightly different trilateral engagement to drive this work forward. Critically, this is not the first time that France has been promoting this agenda. It was tabled by France, South Africa, ILO, OECD, and WHO with a particular agenda and recommendation on women and gender and women's rights in the UN's High-Level Commission on Health, Employment and Economic Growth back in 2016. That recommendation resulted in a whole series of resolutions and the adoption of the Working for Health Action Plan, with women in the workforce one of its core central tenets. So this gender equal health and care workforce initiative has added to that existing engagement and really strengthened the momentum. And as we'll hear from some of the speakers in today's session, we'll hear of excellent progress throughout the year. Thank you all to those who have supported this work, from the partner organizations and all the external parties that have engaged with us. In May of this year at the World Health Assembly, member states requested the Director General to develop in particular through a member state-led process, a new action plan on the health and care workforce. This comes in the recognition of the role of health and care workers at the forefront of the COVID-19 pandemic, at the forefront of our ambitions for universal health coverage. That action plan, led by member states, will be tabled at the World Health Assembly in May next year. We see this as a critical opportunity to bring the evidence, the actions, and to address the gender gaps in the health and care workforce throughout all the health systems, to get this as a central pillar of the next 8 years' actions at the global level, the regional level, and importantly, at the national level. It will enable us to integrate the evidence, the ideas, the proof of what works where into an action plan, and enable WHO's normative work, the leadership functions, to be really driven down to the national level. It will enable us to assess, to review, and provide guidance on the gender transformative actions required to ensure that women have a decent and safe working environment, that they are protected with statutory instruments, that they are given career development and leadership opportunities, and they are free from all forms of harassment and discrimination. As we have learned from our sister UN agencies, institutionalizing gender equality work into national action plans is a strong predictor of sustained progress over time. Importantly, by doing so and by integrating this into the action plan, we will also be able to establish and utilize the policies and reporting mechanisms to assess progress over time, including reporting to WHO governing bodies. The momentum this year, I'm convinced, demonstrates that an evidence-informed agenda can be harnessed and that progress is possible. Let me express my sincere appreciation and thanks to the government of France, to Ambassador Seydoux and her team, to Minister Varane his team, to Women in Global Health, to their chapters all around the world for the positive collaboration this year to really drive this agenda forward. Let me thank also the many partners who are making their own organizational, institutional, personal commitments to the women in the workforce agenda. I wish you all a safe and healthy holiday period, and especially should you be visiting friends and family, to take all necessary precautions against COVID-19. We wish you very well and look forward to working with you in 2022.
Malaria, we know, evolved at least 2.5 million years ago and may have killed more people than any other infectious disease in history. Malaria has changed history, but I am also have been inspired to see how the fight against malaria is changing the world. Just over the last 20 years, over 10.5 million lives have been saved, 1.7 billion malaria cases have been prevented, and 40 countries are now malaria free. Why does that have a link to the health and care workforce and gender equity? Well, because the countries succeeding in beating malaria recognize outbreaks start and stop in communities. They've prioritized reaching the unreached through community health workers. And who are community health workers? They're mainly women who are often without a high school degree, hired directly from their own communities, and trained and equipped to go door to door to test and treat their neighbors with malaria and other diseases. In Liberia, community health workers first trained to find and refer neighbors with symptoms of Ebola during the West Africa Ebola outbreak were later equipped to test and treat children with malaria. Today, 1 of every 2 children in rural Liberia with malaria is treated by a community health worker. And I've seen it with my own eyes as a doctor, having grown up there as well in Liberia, expanding access and to rural communities through community health workers has contributed to a dramatic decline in malaria-related deaths. Rwanda, Senegal, Zambia, Ethiopia, countries I've just been meeting with, our President's Malaria Initiative teams in those countries have worked with governments there to deploy similar strategies, and they've achieved similar results. It doesn't stop in Africa. Our partners in Thailand have cut malaria cases by 90% by training 1 million community health workers over the last decade. And El Salvador used community health workers as part of its strategy to rid the country of malaria altogether. This year, it was certified malaria-free by the WHO. But it doesn't stop in malaria. The independent panel for pandemic preparedness and response, to Jim's point about the role of health workers and women on the front lines during the COVID-19 pandemic, the IPPPR found in a scientific review published in Nature Medicine that over 28 countries that responded to COVID-19, when you evaluate these countries, it turns out that those with lower COVID-19 deaths per 100,000 people made greater investments in community health workers because it helped those countries rapidly find patients and track and isolate and provide social support to those exposed to the virus. I've seen it with my own eyes here in the United States as well as in rural parts of Africa, because these trusted outreach workers share the lived experience of their own communities. They are in fact more effective in persuading and supporting their neighbors to get the vaccine than I might be as a doctor. I say all this, Rupa, with a very hopeful spirit, because we know this is the truth. There is an opportunity to invest more in this workforce for women on the front lines as community health workers. But to do that, we have to confront an injustice. Most community health workers are poor. Most community health workers are women. And most community health workers are not paid fairly, or in some cases, not paid at all. I was surprised to learn in the work that Women in Global Health did with the WHO on a report, a landmark report a couple of years ago. I was surprised to learn that the poorest women on earth subsidize healthcare globally to the tune of $1 trillion every year with their unpaid labor. $1 trillion, that's a figure larger than the economies of over 150 countries. How can the world have health security if health workers that we depend on don't have financial security. So we have to do two things. First, as global health funders, we need to center equity, gender equity in our policies. And that's why I was proud this year that the President's Malaria Initiative has made a new shift in our policy to work with partner countries across Africa and Southeast Asia to formally recognize, professionalize, and pay existing informally employed or unpaid or underpaid community health workers with the focus on women. We cannot stop there. The second thing we have to do is to challenge and demand action from local and national health policymakers. Power is never given. It must be demanded. So we must demand finance ministers, health ministers, and heads of state go as far as it takes to abolish the pay gap for women on the front lines, not only because it's the right thing to do, but because it's the smart thing to do. When you look at global health security, genomic sequencing, and vaccine, things, products get discussed a lot. Well, local public health workers are just as much global public goods as those products and interventions. Investing pandemic preparedness dollars, global health dollars, and health workers keeps us all safer, and they make our economy stronger. For every dollar invested in a community health worker, a country can have $10 of return to their society because jobs are created, outbreaks are averted, and routine healthcare services that help keep people live longer, healthier lives continue. So Rupa, in closing, I would just ask that all of us push others in global health, push domestic and national policymakers, and remember that investing in a community health worker is a fast way to create jobs, jobs that in turn create the fastest way out of pandemics. Thank you.
Thank you, Raj. And couldn't agree with you any more than what you've already said, that power is never given. It must be demanded and taken. And also the really important narrative that you're saying that this is not a cost to society to invest in health workers. It's actually an investment that has a 10-time return. And we exactly need those type of investments to bring our economies back, but also more importantly, continue to build stronger health systems needed for the current pandemic and to build future resilience. And health workers are critical to that. So your message is quite clear, and the investment case is quite clear. So I turn it to Eric. The floor is yours to hear your remarks.
Thank you very much, Dr. Rupa, and thank you very much for this opportunity to present l'initiative's contribution to this joint work on women in health and care. Very quickly, I would like to start in explaining where I'm addressing this audience today. L'initiative is a French set-aside facility set up by the French MOFA to support access to technical assistance, skills building for enhanced access to global fund funding against HIV, TB, and malaria. And in addition, we do provide stakeholders engaged in the fight against the three diseases and in strengthening systems for health with additional catalytic grants. L'initiative, while fueled by the French MOFA through a fraction of the French contribution to the Global Fund, is implemented by Expertise France, the French technical agency for technical cooperation. We have a very long tradition of supporting community-based organizations in many developing countries, especially in sub-Saharan Africa. And as you probably know very well, many tasks related to prevention, to diagnostic and treatment and care are done by community health workers. And l'initiative has just launched a consultation in order to produce new knowledge, because we need more knowledge on the recognition of community work, particularly in the field of the three pandemics, but also in health system strengthening and sexual and reproductive health. And we believe this would be a key contribution to increase visibility, dialogue, and action on gender equality for health and care workers. So why? Because it's obvious, but as it has been already said by the previous speaker, community health workers are also female community health workers, and they are often coming from disadvantaged or marginalized communities. As women are particularly involved in community health work, this may partly explain the precariousness of their status and remuneration. That said, a recent research on community health workers conducted by UNICEF in 2019 under the French Muskoka Fund highlighted the predominance of men among community health workers in West and Central Africa, in contrast to many other regions of the world. So we have gender mainstreaming that poses challenges for community health programs and donors, and I would like to list a few of them. First, I would say recruitment methods and criteria that are not unfavorable to women. That's something that we have to pay more attention. We have also to pay more attention on equity in remuneration and ensuring that institutional recognition does not entrench inequalities in the recognition of men's and women's contribution to community health. And faced with these challenges, the study that we had recently launched on community health work integrates a particular look at what we can say gender dynamics within the various expected works, literature review, case study, and also recommendations. So the initiative intends to question in a cross-cutting way how gender influences the status and recognition of community health workers, and conversely, how community health is affected also by gender inequalities. And I'm stopping here, and I will be more than happy to answer if there are any questions. Thank you very much, Dr. Rupa.
Thank you, Eric, and for highlighting exactly those issues. I turn it next to Dr. Magda Robello. The floor is yours.
Thank you. Thank you very much, Rupa, for giving me the floor and for jointly organizing this important meeting along with WHO and the government of France. I would like to salute the Honorable Minister of Solidarity and Health of France, Mr. Olivier Véran, Ambassador Seydou, the Executive Director of Women in Global Health, Rupa, Director Jim Campbell of WHO, the PMI Coordinator, congratulations, distinguished invited guests and speakers, ladies and gentlemen. I'm deeply grateful and honored for the opportunity to participate in this high-level event commemorating Universal Health Coverage Day and bringing to the fore important aspects of health and care workers, in particular the issue of community health workers, their role, their working conditions, decent pay, among others, one of them being gender parity. I'm going to articulate three major briefs about community health and care worker and community health workers in Guinea-Bissau. I will briefly touch on the reform of our community health workers program that is ongoing, initiated back in 2019 at the time when I was Minister of Public Health. I will also touch upon the community-based active surveillance of SARS-CoV-2 transmission that community health workers are helping with, and the vast community engagement as a response to the pandemic that Guinea-Bissau did put in place in order to address challenges with rumors and perceptions about the pandemic. The previous speaker just mentioned that in West and Central Africa, unlike in the rest of the world, community health workers majority are not women. Indeed, in Guinea-Bissau, the majority of community health workers are male, unlike other places. And the reason for this is deeply rooted in cultural and traditional beliefs we are working to change that, but we are very much aware that it will take a long time because of the systemic and structural challenges, particularly related to education, where women are not favored to go to school. So the reform of our community health workers program was initiated to address poor definition of roles, unpaid work, lack of working conditions, very poor motivation, underperformance, attrition, and poor supervision. Guinea-Bissau has a long tradition of community health and care workers and systems. And we decided to address the issues I mentioned, like attrition. We lost a huge number of community health workers because they were not being paid, they underperformed, and they had poor motivation. And at the center of this reform is progressive achievement of gender parity. It is number 3 in line of the major criteria highlighted for the reform: progressive achievement of gender parity among community health and care workers. Decent pay and enabling working conditions are integral part of the reform. We have designed pay schemes for rural areas, for urban areas, indicating the number of families reached and how would that translate in terms of pay schemes. There are performance indicators and incentives that have been designed along with the interventions package for these community health workers. I should mention that this work is being done in collaboration with UNICEF, the World Bank, and WHO. We have reached the stage of training. They are being trained before deployment, and unfortunately, the pandemic did slow down this piece of work. Let me touch briefly on the community-based active surveillance of SARS-CoV-2 as part of the pandemic response that we did put in place. We have started this work in support, with the support of WHO, and it involves community health and care workers going to families, to households, to do contact tracing and identify the contacts of positive cases that have been diagnosed in health facilities, and making sure that the contacts identified are tracked, tested, and sensitized about prevention of COVID-19. This program is being rolled out. We started in the capital, which is the epicenter of the pandemic, and we are progressively rolling it out to other regions of the country. So the third point I wanted to mention before I conclude is to say that, like other countries developing alike, Guinea-Bissau entered the COVID-19 pandemic unprepared. But soon after, we had an exponential explosion of the number of cases. We elected risk communication and community involvement as a major missing link of our response. We initiated a vast program of community involvement and engagement. We established a system whereby influential community leaders, and by community, we have different groups. Here I'm talking about the youth, women, religious groups, traditional authority leaders, traditional healers, etc., who became our powerful allies at the community, because like the PMI coordinator mentioned, pandemics start and end at the community level. So this community system was put in place and is making a major difference in our response to COVID-19. These people were trained, empowered, and they have spread around the entire country, spreading messages and mobilizing people for testing and doing support to contact tracing. So as a way of conclusion, I would like to reiterate the asks that were put forward by Women in Global Health. If we were to address the barriers created by structures and systems that prevent the goal of universal health coverage and gender equality to be realized, we have to deal with widespread inequalities, of which gender inequality is one such powerful inequality that keeps the world unbalanced as it is. Thank you for listening to me. And again, I'm happy to be part of this conversation. Thank you.
Again, thank you, Magda, for just sharing those insights and highlighting the very pragmatic way that community health workers are currently meeting the health needs of their populations, but also talking about the issues and how it is difficult to retain them if they're not being supported, paid, compensated, all those things that are really critical. But also just, again, building on what's been already said in this panel by Raj and Eric, that this is not a cost to invest in health workers. It's not a cost to invest in, especially the community health workers, but it is truly one that has greater return on achieving the agenda that's needed for our health goals, our health security. And I'd like to thank all of you for really chiming into this important conversation. We're going to transition to our the next part of the program, but very clearly it's been heard that community health workers are part of our health systems. We must use the Gender Equal Healthcare Workforce Initiative to advance a lot of these issues. And I think one of the things this initiative can really do is be the platform, and really appreciate all of you sharing concrete examples in how your own governments, your own projects are integrating the gender agenda, especially when it comes to community health workers. So on that note, I'm really excited to introduce our next speaker, who is a health worker. Her name is Miss Abige Ba Modi. She's the president of the Midwifery Association in Senegal. So I turn it to our colleagues in France to spotlight this. Thank you.
Hello, everyone. Thank you for the invitation. We are very honored to take part in this important meeting to share the experience of Senegal midwives on the subject that bring us together today. In my country, the midwifery profession is exclusively female, with many young women with precarious jobs working in difficult areas where they suffer from remoteness with difficult areas, often neither running water nor electricity, if we know that most deliveries are done at night in rural maternity hospital without adequate equipment. They are also suffering from discrimination in the appointment to position of responsibility. Very often unpaid or poorly paid, because most of them work either for the community or the Health Development Committee without a work contract or career plan, and with a great disparity in salary treatment. Because of a very high employment rate, sometimes women can remain more than 10 years without a stable job. At the beginning of the COVID-19 pandemic, we midwives were left out of the protection of healthcare personnel against COVID-19, which resulted in a significant number of women being contaminated or impacted, more than 120 by the pandemic, including one midwife who died due to lack of space in the treatment center, even though she was a healthcare professional.
Thank you for that message and telling us the stark realities that women health workers are facing. The mere fact that we have trained health workers, yet it takes sometimes 10 years for them to even find some stability in their workplace. So that just shows you how dire the situation is. So I turn it next, as we are reflecting on the year, we're also thinking about what is coming next for us. Really excited to turn it to our next panelist to talk about what's next and exciting in the Gender Equal Health and Care Workforce Initiative. We are going to be hearing about some of the upcoming commitments and other partners that are joining us. So I turn it to Ms. Sultana Afadel. She's the Chief Executive Officer of the World Innovation Summit for Health, an initiative of the Qatar Foundation for Education, Science, and Community. So I turn it to you, Ms. Sultana. Why WISH is supporting the Gender Equal Health and Care Workforce Initiative? Thank you.
Thank you, Rupa. Great, thanks. Hello, on behalf of the World Innovation Summit for Health, WISH, I'm delighted to pledge support for the Gender Equal Health and Care Workforce Initiative. As an organization working in the field of global health, we are acutely aware of the vital role that women play across the health workforce. Women make up more than 50% of frontline workers in healthcare. It is essential, therefore, that they are better represented at the leadership and policy-making level. At WISH, the majority of our leadership are women. Indeed, WISH was founded thanks to the vision of an inspirational Qatari woman leader, Her Highness Sheikha Moza bint Nasser. It is important that pledges are supported by actions. And in 2019, we were proud to commit to a 50% female speaker representation at all our events, a commitment we continue to fulfill today. In partnership with the Washington Global Health Alliance, we are also working to establish a Women's Regional Health Alliance. I'm pleased to be able to say that women's voices are being heard, listened to, and acted upon right across Qatar's health sector. Qatar's health minister is a woman, and as a Qatari woman myself, I have been witness to considerable efforts being made in my country to ensure that women's potential is being realized. It's important that the momentum we've experienced in recent decades continues. Before speaking to you today, I was informed that we were the first organization in the Arabian Gulf to make a pledge to this initiative. I'm sure we will not be the last, and we will certainly be speaking to our many partners across the region in support of this initiative. Across the globe, considerable effort still needs to be made to ensure that women are fully part of the decision-making process, and the Gender Equal Health and Care Workforce Initiative represents a vital step on that journey. I look forward to a future where such important steps become great strides, and I look forward to joining you all and many others on that journey. Thank you.
Thank you, Sultana. And really, we appreciate the commitment from the WISH Foundation and from Qatar also joining and being the first in this region. We look forward to learning from you and working together to advance this agenda. Again, it's very exciting that 2022 will include opportunities on that front. Next, I would like to go ahead and introduce our next speaker here. Just one second. I'm sorry, I'm just having I wanted to confirm that they're here with us. Yes, so I'm turning it to Dr. Justin Coonan, who is the UHC 2030 co-chair. Does not need an introduction this week. Justin, so excited that we were able to have you join us as we are celebrating Universal Health Coverage Day and Week. Turning it to you, how do you see this importance of gender equality continuing, especially as we are closer to the next high-level meeting on universal health coverage in 2023?
Thanks so much, Rupert, to you and Women in Global Health, and also to WHO and the government of France for this opportunity, and happy belated Universal Health Coverage Day. Most of you will know who UHC 2030 is and what we do, but as a reminder, our role is to bring together diverse voices and perspectives from governments, multilateral, civil society, the private sector, philanthropic foundations, in a shared endeavour to strengthen political commitment and promote collective action towards universal health coverage. We're a multi-stakeholder platform to share experience and knowledge and develop guidance and advocacy tools to support more effective and coherent action based on a shared vision to strengthen health systems for both universal health coverage and health security. UHC 2030 recently released our 2021 State of the UHC Commitment Report, which is meant to accompany the official WHO UHC Global Monitoring Report and ask not just what is happening. The Global Monitoring Report does an excellent job at that, but also why things are happening or why not. And this year's review asks a simple question: what actions are governments taking to fulfill their UHC commitments? The review shows that countries have made a wide range of UHC commitments, but that they don't necessarily have a vision for what that action looks like or how to deliver on those commitments. But amidst the commitments that have actually been made, one thing stands out glaringly, and that is the lack of progress on commitments to gender equity. We found that only 6 countries out of the 45 we reviewed have taken action to increase women's empowerment and representation in political and health leadership in line with the 2019 UHC Political Declaration. 13%. It's nowhere near good enough. Global commitments to gender equity, and there have been many of them, are entirely empty unless they're accompanied by concrete changes to practice at the country level. And the first step toward driving these changes is to measure what's actually going on and to hold governments accountable for that. And I think that the Gender Equal Health and Care Workforce Initiative has a central role in doing that. So we at UHC 2030 look forward very much to working with the partnerships of this initiative to make that happen. Thank you.
Thank you, Justin. And it's great to see the connections, but also how we are seeing much more evidence coming out, especially related to what does it mean to make sure that we don't leave anybody behind. We reach the hardest to reach populations. We look at the issues that women are particularly facing in both accessing care, but this change in narrative of women being the drivers of health in their community. And for those that are not familiar with the Universal Health Coverage Declaration, it is one of the strongest, most gender mainstream declarations that has come out from the health community. So we must use this as a political tool. So now I am delighted to introduce actually a new commitment maker. Unfortunately, they're not able to join us live, but I will ask our team from France to very briefly play the video message where we are going to be introduced to the UN University. Particularly, it's Dr. Joanna Riha, who's a research fellow, who is going to share briefly with us building the evidence base for gender equality in the health and care workforce. And this is something that is very critical to the work that we do at the Gender Equal Health and Care Workforce. So I turn it to the France team. We, given the sake of time, we're only going to be playing a few minutes of this video message, but we'll continue to share this on our website and the follow-up.
Hello, everyone. It is such a pleasure to be here as part of this important event as the year draws to a close, and in particular, this panel. I'm sorry I cannot be joining the live discussion. However, I'm really keen to share my reflections and thoughts with regards to this question of, what already exists in terms of indicators or monitoring mechanisms in the area of gender equality that could be an inspiration for the Gender Equal Health and Care Workforce Initiative. And as part of my intervention, I would like to actually draw on findings from a recent project that the Gender and Health Hub completed and co-produced with 5 UN agencies, really looking at what works and what were the successful factors that led to successful gender mainstreaming in health programs and institutional structures and processes. And I'd like to make links between some of those findings, or findings from that project rather, and the work that the initiative is beginning to undertake in terms of thinking about setting up effective monitoring mechanisms and accountability mechanisms as well. So I wanted to make four main points as part of my intervention today. The first was really a need to be outcomes focused. And I think in this way, the Gender Equal Health and Care Workforce Initiative has very concrete areas and very specific asks, which it seeks to drive action, across the 4 pillars. But I think there's also a danger that as we look to create, to to create and identify indicators and accountability mechanisms, that these then become an end, in and of themselves, as opposed to a means to an end. So what I mean here, for example, is, collecting, analyzing, and reporting disaggregated data on the health and care workforce, including the gender composition of leadership, is important. But simply reporting that disaggregated data is not going to lead to increasing the proportion of women, for example, or achieving gender parity. And so it's really a question about being outcomes focused and thinking about how will these indicators be used? What are the accountability mechanisms in place to support the use of these indicators for change? What are the pathways through which various programs, policies, or initiatives can be changed and can respond to what these monitoring and evaluation indicators are showing? Linked to this point, and one of the findings that came out of the What Works piece was, gender parity alone is not going to affect change. It is one step along the way. But it's really ensuring that, women in the right positions, in the right leadership positions are there, but they're also bringing the right technical expertise. And I think that is something really important that needs to be stressed as we're looking towards being prepared to effect change. The second point I wanted to highlight was the need for practice-based evidence to inform what has and what has not worked. So, for example, we all know that there is a long history of calls and commitments for collecting disaggregated data. And, yet when a crisis like COVID-19 pandemic hits, less than 30% of data reported to WHO related to COVID cases was actually reported disaggregated by sex and age. And, that's a very basic level of reporting of data, right? Despite a lot of it being routinely collected. And so it's really important to understand why, what are the obstacles that are preventing these indicators from being collected? And linked to this point is not just focusing on the challenges, but actually looking at successful cases. And in this way, I think a focus, and one of the things that the What Works project did differently was it focused on successful cases and looked at what can we learn from these successful cases and draw out the transferable lessons. And I think in this way, carrots can be at least as important, if not more than sticks. And potentially success begets success, as Gita Rao-Gupta says. And, we can really move things forward by focusing on the successful cases and challenging ourselves to then do better from that successful starting point. The third was a need to really prioritize and strike a balance between collecting meaningful outcome-focused data and indicators with the resources required. And linked to this prioritization and balance is thinking about who is going to be allocating the money, really dedicated to data collection in terms of the indicators that are going to be used for whatever accountability mechanism is set up. Is this funding part of core funding, or is it likely to disappear when a particular funding stream or funder pulls out? And I think that's really important to think about as this initiative moves forward. And linked to this point is, asking for all information to be disaggregated versus prioritizing specific indicators. It links to the very first point in terms of being prepared to change. So maybe identifying areas which can respond and react to indicators that are reported in the accountability mechanisms, and prioritizing those as a starting point, as opposed to overwhelming, overwhelming a system to report on all data that, be it all disaggregated information. And I guess linked to the point of financing, but sort of moving forward, and one of the findings from the What Works piece was a real need to think about not just having an accountability mechanism that looks at allocation and budget allocations for work on gender equality in the health and care workforce, but it's equally important to track expenditure and the changes that resulted as a consequence of that expenditure. So really being, again, outcomes focused and looking at expenditures and the changes that resulted or did not result and reasons why. And the last point I want to make is the need to ask ourselves, accountable to who, right? Who are these, why are we doing this work? Why is this initiative there? And essentially, it is to the respective, health and care workers, women, across the world who are doing this work. And I think in that way, there's really a risk to lose this focus and instead perpetuate, an inequality that often exists, where it's the global north dictating to the global south what indicators, you're supposed to be reporting on. And actually, we should be decolonizing that sort of approach. And one way to do this, I think, is to very, very meaningfully engage with feminist civil society groups on the ground throughout the process of, conceptualizing and developing and implementing this accountability, whatever accountability mechanism is set up as part of this initiative. And building meaningful partnerships with feminist civil society will not only strengthen and create an external accountability mechanism, but will also ensure that the initiative is grounded in the local realities of the health and care workforce and women's realities, right? As well as the ethical frameworks that are required, I think, to underpin a lot of this work. So I'll stop there. Thank you so much once again for having me. It is such a pleasure.
So Dr. Joanna has clearly made, a strong case for us to keep the data piece as a critical part of it. And this is something that was a theme that came out in the Delivered by Women, Led by Men report that's been mentioned earlier in this session today, that we are lacking gender disaggregated data, but even more so intersectionality data and data from low middle income countries. We don't have baseline, and a big part of this initiative is very much calling to fill this data gap. But I think what also stands out is that we need to be capturing where change is happening, where progress is happening, where gender transformative policies are being put into action, and what are we learning from that. So we're really thrilled and look forward to welcoming UN University into this initiative in 2022. And next, I'd like to turn it to a partner, a critical driver of this agenda. The government of France also does not need any introduction, but Ambassador Stephanie Sidhu is the French ambassador for global health. She is very committed to this agenda and has, through her platform and the platform of government of France, really mobilized in 2021 to make sure that this initiative has been successful, not only in global health, but also in the gender equality discussions that's been taking place. So Stephanie, I turn it to you to give us a preview of what can we expect, what is coming next in 2022, and what do you see as an opportunity, especially as the lead government in this initiative?
Thank you so much, dear Rupa, and all of you, ladies and gentlemen, and in particular, dear health and care professionals. This is really, it's been a spectacular year. In 2021, we really have managed through this initiative, I believe, to bring light onto women who save our lives every day at the cost of their own lives, as we were reminded by the powerful testimony of Mrs. Bigueba Mbodj from Senegal just now. So this is what we do with this initiative. We want the women to be, who save our lives, to be recognized, honored, and heard. And this has to be done with a continued motivation and energy. So what we have seen in this first year of the Gender Equal Health and Care Workforce Initiative is really a strong convergence of all stakeholders in favor of new standards, changing things, shifts which need to happen to promote and protect women health professionals. And I think the interventions we've heard today really go in that direction and reinforce that convergence. I want to quote 4 points. One is, we no longer can accept to underpay or not pay women in health, whether in public sector or in development projects. And we have to avoid resorting to voluntary work, which is in effect unpaid work to provide health services. No longer acceptable. Second point is to set a benchmark to ensure sufficient investment, public and private, in health in order to secure the necessary resources which will guarantee proper work conditions, including salaries for health workers. The third point is to no longer accept violence, harassment, and discrimination against women health workers. And this can be done through enforcement of the ILO Convention number 190 on combating harassment at work, which all governments supporting this initiative should ratify. And fourth, we must and don't want to anymore accept, we must no longer accept that health issues be discussed and decided upon without women participating in the process. And in order for women to be at the decision table, well, we have to ensure and guarantee that they receive appropriate education, training, and benefit from a supportive environment along the way. So we have started on this journey. We must keep up the pace. And I would like to express my deepest thanks to our speakers today, to all the states, the international organizations, the NGOs that have joined us and engaged since last February. Strong and significant commitments have indeed been made. And now these commitments must be translated into concrete action on the ground. And this is what we'll do in 2022, the year of action. And in order to create and help real change to come about in practice, structures, behaviors, in hospitals and clinics, in retirement homes, in community health centers, our initiative must translate into differences in country. And this must go beyond the international mobilization in our capitals in Geneva or in New York. And we have to indeed meet the expectations of millions of women. And therefore, we suggest that a follow-up to the initiative be put in place. So this could happen on a regular, voluntary basis via future events of the initiative, and we could call on interventions such as those which were we heard today, and it was absolutely great to hear from the United States, from Guinea-Bissau, from WISH, and from UNU, of course, UHC as well, who are joining, who are strengthening the ranks of those who want to get involved. And so I think this is something which we must keep up, and also invite those who want to keep us posted on how things are going to indeed be able to take the floor in those meetings and to be planned along the way in 2022. I think we must also indeed resort to accountability mechanisms, and the Generation Equality Forum, which was such an important event in July this year, is probably the right forum for that. And we should ensure that the follow-up mechanisms of the Generation Equality Forum do take into account our work here in the initiative. So this is another way we can ensure follow-up and accountability. And finally, we welcome very much the Working for Health 2022-2030 action plan, which is drafted by the World Health Organization, which will provide new tools to address action and to address follow-up with, in particular, guidance regarding data collection, of which we've just talked, and to underline how crucial it is. And we know that this is absolutely key. Now, on this action plan, a consultation process has just been launched and will be, I understand, intensified at the beginning of the year with a view for its adoption at the 2022 World Health Assembly. And it is important that all stakeholders who've chosen to be involved in the Gender Equal Health and Care Workforce Initiative to also get involved in this process of taking part in the consultation in this very important document. So we therefore call on all people, institutions, and organizations which are involved in the initiative to to start on this work. We will get back to you at the beginning of 2022. And I am, on this note, also very pleased to thank again Women in Global Health and its wonderful director, Dr. Dutt, for being such a strong force and a powerful engine in bringing us forward. We are also very keen to put this the event online, so we will make sure that it can be made accessible to all of you after the end of the event. Thank you very much.
Thank you, Ambassador Sudhu, and mutual gratitude to you, the World Health Organization, for being our partners this year to initiate this important work that we have started, as well a really special thanks to all the organizations, all the governments, all the institutions that have stepped up and joined in making commitments, and looking forward to welcoming the new ones in 2022. A special thanks to our speakers and panelists today for prioritizing joining today, and all the panelists, again, for the very deep reflections on where we need to go. Taking your words, Stephanie, making next year the year of action. Also, thank you to all our attendees for joining today's conversation. And as we close, a really clear reminder, we know that gender equity is a critical aspect of strengthening health systems, achieving universal health coverage, and making sure we have health security. We also this week had the Global Health Promotion Conference. 35 years later, the Geneva Charter has been launched, which makes a strong commitment to, again, investing and protecting health workers as critical to health promotion. So it's great to see all these agendas, reminding us that we need to work on health workforce, but let's make sure we do this in a gender equitable way. We cannot be surprised if we don't take action, because we are hearing from health workers. You've heard from the midwife today about the conditions that women health workers and all health workers are facing, that there is a great resignation that is happening. It's a critical issue of today. We are seeing great resignation of health workers in high-income countries, already 20% leaving the workforce. This is going to have an impact on health systems, especially in low middle-income countries, as we see a great migration with this great resignation. So as we face this pandemic, face the global shortage of 18 million health workers worldwide to achieve universal health coverage, I call on you to invest in a gender equitable way. And if we get this right, we get the triple gender dividend. We get a return, as we've heard. We get a health dividend, which will help us achieve a universal health coverage and fill 18 million health worker jobs. We'll get a gender equality dividend. When women have decent jobs, they gain more income and decision-making power. And third, we'll also get an economic dividend. We've heard there's new jobs created for every health job, and it will fuel broader economic growth, which is also critical to getting ahead of what we're facing. This will be a win-win solution. So in closing, we call for a new social contract, which is based on a new social contract, especially for women health workers, but benefits all health workers on decent work, safety, dignity, fair pay, and equal leadership, so that they can do their jobs better and deliver the best possible health promotion and healthcare for everyone. So again, thank you for joining today. As we close, we have a final video just to say thanks to all those that have joined us this year. Thank you. Thank you, everyone. Stay safe, stay well. See you in 2022. Bye-bye.